Welcome to the deep dive. Today we're tackling a really important topic, carotid artery stenosis.
Right, that narrowing of the arteries in your neck, the ones feeding the brain.
Exactly. And our sources for this are chapters from Rutherford's Vascular Surgery and Endovascular Therapy, the 10th edition. We're really going to unpack carotid artery stenting, or CAS.
Yeah, our mission here is really to give you a clear, sort of concise understanding of how carotid stenosis is treated with these stenting techniques.
We'll look at the different methods, how doctors choose, the right approach for a patient.
And what the latest evidence tells us. Basically, get you up to speed without getting totally bogged down in, every single detail.
Okay, so let's jump in. This idea of treating these narrowed arteries without the big open surgery, it actually goes back a ways.
It does. 1977 saw the first reports using these endovascular techniques.
Like angioplasty, similar to what they use elsewhere.
Pretty much, yeah, using those peripheral angioplasty techniques. And there was some early success.
Then came the stents.
About a decade later, around 87, balloon expandable stents. And this is where it got, well, interesting.
How so?
Well, there was a lot of initial excitement, for treating really bad blockages, high-grade stenosis.
Right.
But the early results, they showed higher stroke rates than expected, around 6 to 9%. That dampened the enthusiasm a bit.
Okay, I see. That's quite high.
It was. But what's fascinating is how that setback kind of spurred innovation.
Ah, right.
The introduction of cerebral protection in 1990, that was a real game changer.
Leading to EPDs, Embolic Protection Devices.
Exactly, EPDs. And these devices, they significantly cut down those stroke rates. Really renewed interest in this whole endovascular approach.
And more recently?
More recently, we've seen TCAR emerge. Transcarotid Artery Revascularization often uses flow reversal to protect the brain, another promising technique.
So today, we're really focusing on two main stenting methods.
Right.
First is transfemoral carotid stenting, TFCAS. Access through the femoral artery in the groin.
Yep, that's the one.
And the other is TCR, Transcarotid Artery Revascularization. More recent, direct access to the carotid in the neck.
Often using that flow reversal for neuroprotection, as you said.
Now, to really get these stenting approaches, we need context. For a long time, a standard was surgery, wasn't it?
Absolutely. Carotid endarterectomy, or CEA, surgically removing the plaque, that's been the gold standard for ages.
So naturally, when TFCS came along, it got compared directly to CEA.
Exactly. Head-to-head comparisons.
And how did that shake out in the trials? It sounds a bit complicated.
It is a bit mixed, yeah. Several big randomized controlled trials, RCTs, did compare them.
Like Sapphire and ACTI.
Right. Those found TFCS to be non-inferior to CEA.
Non-inferior meaning not worse, essentially.
Pretty much. Not significantly worse than the standard, even if maybe not definitively better.
But not all trials agreed.
No. Others, like EVA3S and SPACE, actually show higher rates of stroke or death around the time of the procedure with TFCAS.
And what about CREST? That was a big one.
CREST also pointed to higher stroke rates right around the procedure with TFCAS, though interestingly, it showed lower rates of myocardial infarction, heart attacks.
So higher stroke, lower MI, a trade-off.
Kind of looked that way.
Yeah.
And it raised some important questions about those early trials.
Like what?
Well, criticisms about generalizability, how widely the findings applied. Many were done before modern best medical therapy really became standard.
Okay.
And there were also concerns sometimes about whether the training and experience levels were really balanced between the doctors doing the stenting versus the surgery.
That makes sense. Okay, so that clarifies the TFCAS versus CEA pictures somewhat. Now let's shift to TCO. You said it's newer. What did the trials tell us there?
Well, here's the thing. We don't yet have those big, direct, head-to-head randomized controlled trials comparing TCR to TFCS or CEA. Not on a large scale.
So what do we have?
We have some really promising observational data. From clinical trials, yes, but also registries, like the Roadster trial and the SVS Vascular Quality Initiative TCR Surveillance Project.
Okay, tell us about Roadster first. That sounds interesting.
Yeah, Roadster reported a really low overall rate of stroke or death around the procedure, just 1.4%.
That is low.
And the one-year data looks good, too. Low incidence of ipsilateral stroke, that's stroke on the same side as the treated artery, only 0.6%.
So the conclusion there was?
The authors suggested TCR could be a safe, durable option, especially for patients considered high risk for the traditional open surgery CEA.
And the SVS VQI project, that sounds like real-world data.
It is. Big registry data.
Yeah.
And retrospective analyses looking back at that data, They indicated pretty similar in-hospital stroke or death rates for TCR compared to CEA.
Even though TCR might be used in higher risk folks sometimes.
Exactly. Rates were around 1.6% for TCR versus 1.4% for CEA. And interestingly, they found a lower rate of cranial nerve injury with TCR.
Okay. And how did TCR compare to TFCI in that registry?
TCR actually showed a lower rate of in-hospital TIA, stroke, and death compared to TFCAS. And that difference seemed to hold up even after they adjusted for other factors.
Wow. And longer term.
At 1 year, TCR was still linked with a lower risk of ipsilateral stroke or death compared to TFCA.
So putting it all together, the general vibe on TCAR from this data is...
Based on this non-randomized data, yeah, it looks like TCR outcomes are comparable to CEA, the gold standard, and potentially maybe even improved outcomes compared to TFCA.
Okay, so this brings us to the current guidelines. Given all this trial data, some mixed, some promising, how does the medical community view carotid stenting now?
Well, because those RCTs generally suggested that higher stroke risk with TFCAS compared to TEA.
Right.
The current guidelines for using TFCA are somewhat limited, restricted.
Really, still use.
Oh, yes. There's general consensus support for TFCAS in certain patients, specifically symptomatic patients with high-grade stenosis, who are also at high medical risk for open surgery.
What about lower risk patients? Or those without symptoms?
Yeah, the support is less strong there. Using TFCAS in lower risk folks without prior neck issues, or in asymptomatic patients, it's less well supported by the guidelines. Although some reports suggest considering it in lower risk patients if they have specific anatomic challenges that make CEA tricky, like restenosis after a prior procedure, or if they've had neck radiation.
So some nuance there, but generally cautious on TFCAS.
Fair to say, yeah. Many societal guidelines are cautious about its long-term viability.
And the SVS, the Society for Vascular Surgery.
Their guidelines actually recommend medical therapy over carotid stenting for asymptomatic patients who are deemed high risk for CEA.
Interesting. And where does TCA fit into these guidelines?
That's the thing. Most existing guidelines were written before TCA really became widespread, so its role isn't fully defined in those yet. That's likely to evolve.
Okay, so guidelines are evolving. Let's talk about patient selection. Who actually gets considered for these stenting procedures? What factors are key?
Patient selection is absolutely critical. For TFCAS, there are quote-specific criteria, like from CMS, Medicare, and Medicaid.
What do those generally say?
Usually requires high-grade stenosis, confirmed by angiography if needed. Plus, the patient typically needs to be symptomatic and or high risk for open surgery.
High risk due to what?
Medical problems, like severe heart or lung disease, or anatomic issues like prior neck radiation or a previous CEA on that same side.
Gotcha. But beyond those formal criteria, other things matter too, right? Like age.
Definitely. Age is a big one. And it's interesting. You might initially think, oh, stenting is less invasive, must be great for older patients.
Yeah, that seems intuitive.
But the data actually showed something, well, unexpected. The risk of adverse events with TFCS was actually higher in older patients compared to CEA.
Really? How so?
Yeah, looking back at trials like SPACE and CREST, they found the risk of stroke or death after TFCS went up with age. But the risk after CEA was more consistent across age groups.
And other studies confirm this.
Meta-analyses, population databases, they pretty much supported this pattern. Increased risk with TFCAS versus CEA, starting around age 70 or so. A Cochrane review also found a higher risk with TFCAS over 70.
So maybe TFCAS is better for younger folks.
That's been suggested, yeah.
Any idea why older patients might have higher risk with TFCAS?
The prevailing theory relates to the aortic arch, the big artery leaving the heart, and the proximal common carotid artery. Older individuals often have more plaque, more atherosclerosis in those areas.
And the transfemoral approach goes through there.
Exactly. Navigating those areas with wires and catheters from the groin becomes riskier, more chance of knocking plaque loose.
Okay. How does TCAR fit into the age picture, since it avoids the arch?
Good question. Smaller studies suggest TCR might be equally safe regardless of age in high-risk patients.
And the VQI registry data?
Also interesting, it found no difference in TCR outcomes across age groups even up to 80 and older, and actually showed lower stroke rates with TCR compared to TFCS in patients 80+.
So TCR might be a better option for older patients needing intervention.
It seems promising in that regard. In fact, age 75 or older is now a published indication, a reason to consider TCR.
Okay, what about gender? Any clear differences in how men and women do with stenting?
It's less clear-cut than age, I'd say. The data is a bit more conflicting regarding gender-specific effects.
How so?
Well, one analysis of CREST suggested a higher perioperative risk, mainly stroke, in women having TFCS compared to CEA. But outcomes were similar in men, regardless of the procedure.
But other studies found differently.
Yeah, a big European meta-analysis showed pretty equivalent outcomes for TFCS and CEA for both sexes. And another big combined analysis later supported that conclusion that gender doesn't seem to significantly affect risks after either treatment.
Conflicting data. Any clues why?
There's some interesting observational data looking at the debris caught in EPDs during TFCAS. It hinted that maybe symptomatic women have larger debris particles than asymptomatic women, a difference not seen in men.
Which aligns with the CREST finding of higher risk in symptomatic women with TFCAS.
Potentially, yeah. Maybe it's due to differences in plaque morphology, the plaque characteristics, in symptomatic women, making TFCAS riskier for them.
And TCAR and gender.
Not really described yet. We don't have solid data on how sex influences TCR outcomes specifically.
Oh, okay. Another factor you hear about is the hostile neck. What does that mean?
A hostile neck usually means there's been prior surgery or radiation therapy in that area. Leads to scarring, fibrosis, makes the tissue stiff and difficult to work with surgically.
So stenting might be preferred?
Often, yeah. TFCAS is considered to potentially reduce the risk of injuring cranial nerves during a difficult open surgery in a hostile neck.
Is there evidence for that?
Yes. A systematic review found TFCAS was feasible and safe in post-radiation stenosis, at least in high-volume centers. And a meta-analysis showed similar stroke risk between TSDS and CEA in hostile necks, but a significantly higher risk of cranial nerve injury with CAA.
So it's now a recognized reason to lean towards TFCS.
It is. Hostile neck is an indication to consider TFCAS over CEA in current guidelines.
And TCAR in a hostile neck.
The Roadster trial included a fair number of patients with hostile necks, over a third, and they reported only one temporary cranial nerve injury. The TCAR looks like a viable option there, too.
Okay. What about restenosis, the artery narrowing again after treatment?
That's always a consideration. CREST data showed pretty similar rates at 2 years, actually, around 6% for both TFCAS and CEA.
And what if someone needs treatment for restenosis after a prior procedure?
Data from the VQI suggests TFCAS after a prior CEA or even a prior TFCA seems reasonably safe. Low estimated 30-day stroke risk.
And TCAR for restenosis.
Some institutional data reported very low, even 0%, 30-day stroke risk using TCR for restenosis.
But we don't fully understand the long-term significance.
Not entirely, no. The clinical importance of restenosis and exactly when to intervene again isn't perfectly defined.
So the current recommendation is?
Generally consider TFCAS or TCAR only for severe restenosis and have it done by experts at experienced centers.
Got it. Are there situations where carotid stenting is just completely ruled out? Absolute contraindications?
Yes, absolutely. Active infection is a big one. High risk of the stent getting infected.
Makes sense.
Also, if you simply can't get vascular access to the carotid artery, if multiple access routes fail, CEA might be the only option left.
Anything else?
Inability to tolerate antiplatelet therapy, that's essential after stenting to prevent clots. If a patient can't take them, stenting is usually out.
And specific to TCR?
For TCR, if both femoral veins are blocked, you can't do the flow reversal part. And if there's significant disease right at the access point in the common carotid, that would prevent transcervical access.
Okay. And relative contraindications, things that make it riskier but maybe still possible?
For TFCS, yeah. Older age, as we discussed. Heavily calcified plaque, especially if it goes all the way around. Severe twists and turns in the artery, sharp bends.
Like 2 90-degree angles?
Yeah, things like that. Also, a near occlusion, that string sign, makes delivery tricky. And significant twisting or calcification in the aortic arch itself.
What if you can't deploy an EPD?
That's a relative contraindication for TFCAS. Although TCAR with flow reversal can sometimes get around that problem.
And EPD use is standard now for TFCAS.
Absolutely. The high stroke rates in some early European trials were largely blamed on inconsistent EPD use. It's now considered standard of care, mandated even by CMS.
Let's shift to anatomy in a bit more detail. The aortic arch sounds critical for TFCA.
It really is. The shape of the arch, where the head and neck vessels take off, matters. Types 2 and 3 arches, where they branch off lower down, make it harder to maneuver the catheters and delivery systems up from the groin.
Requiring special tools.
Sometimes, yeah. Reverse curve catheters can help. But type 3 is particularly challenging. More manipulation needed, which increases the risk of knocking plaque loose from the aorta itself embolization.
And you mentioned shaggy aorta and eggshell aorta before.
Right. Those are also major concerns for TFCS. A shaggy aorta has lots of loose, irregular plaque, high risk for atheroembolism. An eggshell aorta is heavily calcified, brittle, prone to dissection or embolism, and just makes manipulating wires very difficult and risky.
So for those complex arches?
TCAR should definitely be considered over TFCS, as it completely avoids manipulating the aortic arch.
Okay. What about the carotid artery itself? Tortuosity and plaque?
Big factors. How twisty the artery is, the plaque burden. They affect getting the EPD and stent where they need to go.
Any specific angles or features?
Some data, like from EVA3S, linked a sharp angle over 60 degrees between the internal and common carotid arteries to higher stroke death risk after TFCAS.
And if the internal carotid itself is very twisty?
Especially distally, further up, it can make positioning the EPD difficult. Severe bends near the end of the lesion can cause flow issues or kinking after the stent goes in. And tortuous vessels are just generally more prone to vasospasm at the end.
What about the plaque characteristics within the carotid?
Circumferential plaque, going all around, makes the vessel stiff, harder to cross, and raises embolization risk during manipulation.
And the string sign lesion. Very tight.
Makes stent delivery tough, yeah.
Yeah.
And there's a risk the stent won't expand fully, leading to early restenosis.
Does the length of the plaque matter?
It seems to. Meta-analyses and CREST data showed that longer lesions, say over 10 or 13 millimeters, had a higher risk of death or stroke after TFCAS compared to shorter ones, or compared to CEA for similar lesions.
And plaque appearance on ultrasound? Echolucency.
That's been linked to increased stroke risk in TFCA too. More echolucent or darker plaque might be softer, more unstable, but the reproducibility of that measurement isn't great, so it's not really used routinely for risk stratification.
One last anatomy point. What if the other carotid artery is completely blocked? Does that influence the decision?
Generally, it shouldn't. Typically, contralateral carotid occlusion shouldn't rule out stenting on the affected side.
Really, doesn't that seem riskier?
You'd think so, but registry data and retrospective reviews show pretty low complication rates for both TFCAS and even CEA in these patients.
What about TCAA data?
The SVS VQI data on TCAR showed similar in-hospital stroke rates, whether the contralateral artery was occluded or not, though there was maybe a slightly higher risk for symptomatic patients with a prior stroke undergoing TCAR if they also had a contralateral occlusion.
Interesting. But CMS lists it as an indication for TFCA.
They do cite it, yeah. Though it's not universally accepted as a high-risk factor, warranting stenting over other options in all cases.
Okay, moving towards the procedure itself, what about preoperative imaging? What's needed?
Imaging beforehand is key. CMS requires angiographic proof of the stenosis before stenting, either done beforehand or during the procedure itself, usually supported by a duplex ultrasound first.
And duplex ultrasound is the workhorse?
For most patients, yeah. Gives a good look at the extracranial anatomy, the arteries outside the skull, and assesses the hemodynamic significance, how much the blockage affects blood flow.
What if the ultrasound isn't clear?
Then MRI or CTA, CT angiography, can be really helpful. CTA is great for looking closely at the plaque, measuring vessel diameters for stent sizing, and just confirming the anatomy is suitable for the planned approach.
And timing, especially after an acute stroke. You mentioned CEA is generally preferred early on.
Right. The data generally favors CEA over stenting in that acute stroke setting. CEA seems to provide maximum benefit within about 14 days of the event, assuming the patient is stable.
And stenting early is riskier.
Several big trials and analyses found the highest risk of stroke or death with TFCAS versus CEA when it was done within the first week or two of symptoms. Registry data back that up too.
So the guidelines reflect that?
Yes. Current European and U.S. guidelines recommend revascularization within 14 days when appropriate, but generally favor CEA over stenting in that early time frame.
And TCR in that acute setting?
We just don't have much large cohort data on TCAR outcomes, specifically in recently symptomatic patients, especially within that first 2 weeks. More research needed there.
Okay, let's get into the technique itself. During the procedure, what kind of monitoring is essential?
Continuous monitoring is crucial. ECG for heart rhythm, pulse oximetry for oxygen levels, and definitely intra-arterial pressure, monitoring a line right in an artery for beat-to-beat blood pressure.
Why the invasive pressure line?
Because you need to react immediately to any significant drops or spikes in blood pressure or changes in oxygen or heart tracings. Things can change quickly.
And anesthesia? Awake or asleep?
Depends on the technique. For TFCAS, usually awake with local anesthesia.
Why awake?
So you can do continuous neurological assessment, asking the patient questions, checking their strength. It's a direct way to monitor brain function.
And TCA?
TCAR is frequently done under general anesthesia, but sedation with local is also possible in some patients.
Are other brain monitoring tools used, like EEG or TCD?
They can be. EEG can pick up subclinical changes, but its real value in an awake, stable patient is debatable, not considered essential.
And TCD, transcranial Doppler?
TCD uses ultrasound through the skull to listen to blood flow and supposedly differentiate emboli. But its accuracy is inconsistent. Its use is pretty surgeon and center specific, not universally adopted.
Let's talk access again. How exactly do they get into the artery for TFCAS versus TCAR?
Okay, TSCAS, traditional is transfemoral, usually the right groin if the operator is right-handed. Left femoral is second choice. Full heparin dose once the sheath is in.
And TCA?
Direct transcervical access to the common carotid. Can be done percutaneously with ultrasound or, more commonly, a small surgical cut down to see the artery. Use a micropuncture kit, insert an 8-French sheath over stiff wire, sometimes use umbilical tape around the artery for stability.
Are there other less common access routes?
Yes, sometimes transbrachial or transradial through the arm. Used if the groin access is hostile or the aortic arch is really bad and the patient isn't suitable for TCI or CEA. Right radial can even work for left or right carotids in some arch types.
Once access is established, how do they reach the actual blockage?
For TFCAS, there are a couple of main platform types. One is sheath-based. A long 6-French sheath sits in the descending aorta. A pre-shaped catheter navigates up to the common carotid, CCA. An exchange wire goes into the mid-CCA, and then the sheath is advanced up over the catheter.
Pros and cons.
Good support, but advancing that sheath carries a risk of snow-plowing plaque off the aortic wall.
And the other TFCAS platform?
Guiding catheter-based. A larger 6 or 7 French guiding catheter goes directly into the CCA and stays there. Minimizes exchanges, good for shaggy aortas. Risk is it can get dislodged. Sometimes a buddy wire in the external carotid helps stabilize it.
And TCA access to the lesion?
Much more direct.
Yeah.
After exposing the CCA, use that specialized micropuncture kit for direct access, then insert the 8-French sheath.
Angiography comes next, the X-ray pictures.
Yep. Once the working platform is stable in the CCA, they inject contrast and take pictures. AP, front to back, and lateral views are standard. Oblique views if needed to see the lesion clearly without overlap.
What about rotational angiography?
Can be helpful sometimes for a 3D view of the stenosis. They're doing fewer pictures way up in the brain circulation now, though, due to concerns about air embolization risk.
Okay, neuroprotection. Super critical. Let's break down the types again for TFCS.
Right. For TFCA, EPD use is standard, mandated even. Lots of models exist.
Filter types are most common.
By far. You pass the filter on a wire across the lesion, deploy it distally in a straight segment of the internal carotid artery, ICA. It catches debris during stenting, allows blood flow to continue. Then you recapture it afterwards.
Advantages.
Uninterrupted flow, you can still do angiography, relatively few manipulations.
Disadvantages.
You have to cross the lesion before protection is up, which is a risk. Potential for vasospasm. Can be hard to retrieve if it gets packed with debris.
And flow reversal, that's mainly TCIR, right?
Yes, the en-route system for TCR is the main example. You establish that external shunt circuit between the CCA sheath and a femoral vein sheath with a filter in between. Creates continuous arteriovenous flow reversal.
Big advantages of that.
Avoids aortic arch manipulation entirely. Avoids needing a balloon in the external carotid. Protects before crossing the lesion.
What about distal occlusion balloons? Less common.
Less common now, yeah. Inflate a balloon in the distal ICA, block flow completely during stenting, then aspirate blood and debris before deflating.
And proximal protection, like MoMA.
Also an option for TSCA. Uses occlusion balloons in both the CCA and external carotid artery, ECA, via a single catheter. Creates flow stasis during stenting. Aspirate debris afterwards.
Advantage there.
Avoids crossing the lesion before protection is established.
Disadvantage.
Needs a larger sheath. And maybe 5% of patients can't tolerate the flow stasis or reversal hemodynamically.
Okay, neuroprotection covered. What about predilation? Inflating a balloon before the stent.
Decision depends on how tight the stenosis is. Brief predilation with a small balloon, maybe 2.5 to 5 millimeters, at low pressure can help make space for the stent.
But not always needed.
Rarely needed just to get the filter across. If you can't get a filter across, maybe consider a proximal protection EPD instead of forcing predilation.
Then the stent itself. Selection. Delivery.
Self-expanding stents, stainless steel or nitinol. Choice depends on anatomy and plaque. More flexible stents for tortuous arteries. Maybe better scaffolding for plaques prone to protrusion.
Nitinol versus stainless steel.
Nitinol generally has higher radial force, might be better for calcified plaques. No real consensus on open cell versus closed cell designs being better overall.
Any evidence on cell design?
ICSS trial and meta-analyses showed conflicting results on things like rest stenosis or new MRI lesions. But importantly, no clear difference in actual stroke rates between designs.
Post-dilation, ballooning after the stent is in. Used to be common.
Historically, yes, but VQI data suggests routine post-dilation in TFCAS might increase perioperative hemodynamic depression, stroke, and even death.
Why?
Not entirely clear, maybe more baroreceptor stimulation or plaque disruption. Plus, stents continue to expand somewhat on their own over time.
So the current thinking is
Reserve post-stent ballooning only for cases with significant residual stenosis after stent deployment. Applies to both TFCAS and TCAR.
final steps. Completion angiography.
Yes, always done in at least 2 planes with neuroprotection still active. Check stent position, residual stenosis, any distal spasm, plaque protrusion through the stent struts.
And watch for spasm after EPD removal.
Especially after filter removal, yeah. Watch the distal ICA. Usually resolves spontaneously. Nitroglycerin can be used if needed, then retrieve the EPD carefully.
Finally, access hemostasis, closing the hole.
Heparin reversal with protamine seems safe for both TFCAS and TCAR, reduces bleeding without clearly increasing clot risk.
How is closure done?
TFCAS, usually percutaneous closure devices, sometimes combined with manual pressure. TCA, the CCA arteriotomy is closed with a pre-place U-stitch, usually without reclamping the artery.
Okay, let's talk perioperative medications. Anticoagulation first.
TFCAS, full heparin, usually 70-100 units per kilogram after sheath access before manipulation. TCAR, full anticoagulation before CCA access. Keep the ACT below about 300 seconds to minimize bleeding risk in the brain.
Anticholinergics, like atropine. Why?
To treat or prevent hemodynamic depression that drop in blood pressure and heart rate. Can happen after ballooning or stenting due to stretching the baroreceptors in the carotid sinus.
More common when?
Older patients, calcified plaques,
Yeah.
can be linked to worse outcomes if severe. Pre-treatment with an anticholinergic is routine for TCAR before dilation, unless contraindicated.
How is severe hemodynamic depression treated?
Aggressive fluids,
Right.
atropine. Vasopressors like phenylephrine or dopamine are less commonly needed but can be used. Sometimes hypotension persists for 24-48 hours. Manage supportively until baroreceptors adapt.
Any risk factors for it?
Short distance from bifurcation to stenosis, eccentric stenosis, echogenic plaque, calcification right at the bifurcation.
What about vasodilators?
Often used intravenously throughout TFCAS to keep systolic BP below about 180 mmHg. Helps minimize intracranial hemorrhage risk. Nitroglycerin for ICA spasm after EPD removal, as mentioned. Just need to avoid excessive vasodilation if there's also hemodynamic depression.
And vasopressors. You mentioned them for severe hypotension, but also used differently in TCR.
Yes, in TCR doing flow reversal, they often prefer mild hypertension to ensure good cerebral perfusion while the CCA is clamped. Vasopressors, often phenylephrine, are used to keep systolic BP above 160 mmHg during that clamp time, often combined with the anticholinergic pre-treatment.
Antiplatelet therapy, absolutely essential, right?
Critical. Data from coronary stenting shows clear benefit. Carotid stenting guidelines recommend dual antiplatelet therapy EPDs, usually aspirin 81-325 mg daily, plus clopidogrel 75 mg daily.
Timing, duration.
Start DABT at least 4 days before TFCS, continue for a minimum of 30 days after. For TCR, ideally start clopidogrel at least 7 days pre-op, or give a loading dose 4 hours prior if urgent.
Alternatives, contraindications.
Ticlopidine, if clopidogrel intolerant. Global intolerance to antiplatelets is an absolute contraindication to stenting.
And statins. Everyone gets them.
Yes. All patients being evaluated for carotid stenting should start statin therapy preoperatively if not already on it.
Why?
Meta-analyses show reduced mortality after vascular surgery with pre-op statins. They reduce cardiovascular events, benefit likely within a month. TFCAS patients on pre-op statins have lower 30-day stroke death rates.
Optimal timing dose.
Unclear, but consensus is start as early as possible. No specific data quantifying benefit in TCR yet, but the en route system instructions actually specify atorvastatin pre-treatment.
Okay, let's face the potential downsides.
Yeah.
Complications, technical ones first.
Acute stent thrombosis is a nightmare scenario. Clot right in the stent. High stroke risk. Causes can be misplacement, stent recoil, plaque protrusion. Immediate conversion to open CEA is usually the best bet.
Kinking.
Can happen as stent ends, especially in tortuous vessels. Mild kinks without flow limitation might be observed, can remodel. Severe kinks need post-stent angioplasty, maybe another stent.
Carotid dissection.
A tear in the artery wall can be observed if small, non-flow limiting, or managed with balloon apposition or another stent, depending on severity. If it limits flow, definitely need another stent to tack down the flap. Crucial to keep wire position in the true lumen.
Neurologic complications. The big worry. Embolism.
Most common, most feared. Usually bits of plaque or thrombus off the catheter. Diagnosed by intraop neuroexam changes in angiography. Neurorescue options exist: thrombolysis, thrombectomy, but results vary. Prevention is absolutely key.
Intracranial hemorrhage, ICH. Bleeding in the brain.
Rare, thankfully, but devastating. Maybe slightly higher risk with TFCS than CEA in one study, but RCT data generally shows equivalent low risk, less than 1%. Crest suggested maybe ICH after TFCS is more severe when it does happen.
Risk factors for ICH.
Symptomatic stenosis, maybe severe bilateral stenosis plus hypertension.
Hyperperfusion syndrome.
Uncommon, 1–2%. Presents usually hours later with ipsilateral headache, maybe neuro changes, brain edema on CT without a clear stroke. More common in hypertensive patients or those with recent TIA, carries a risk of progressing to ICH. Treatment is supportive, tight BP control.
And subclinical neuro stuff, those MRI spots.
Yeah, microembolic events. New lesions on DWI MRI are seen much more often after TFCAS than CEA in some studies, even without clinical symptoms. The concern is potential long-term cognitive loss, but current data doesn't clearly show worse long-term cognitive function after TFCAS. Still being studied.
Cardiovascular complications.
Heart attacks. Perioperative MI risk is consistently lower after TFCAS compared to CEA and ERCTs.
And TCAR.
Benefit for preventing MI with TCR isn't established yet, but both TFCAS and TCR might be good options for patients with high cardiac risk for open surgery.
And hemodynamic depression, long-term effects.
Usually transient, rarely causes long-term ischemic events or persistent BP changes.
Access site complications, groin or neck issues.
Hematoma, pseudoaneurysm, peripheral embolization down the leg, infection. Can happen. BQI data showed similar overall bleeding rates for TF-CAS-CAR, but TCR bleeding was more likely to need intervention. Most are self-limiting, decrease with experience. Ultrasound guidance, protamine reversal, closure devices all help minimize these.
Stent fracture, how common? Serious.
Reported in maybe up to 9% of cases, detected months or years later. Only about 11% of those were symptomatic stroke, hematoma, non-specific symptoms. Stenosis was seen in over half of fracture cases, often needing reintervention. But the ACTI trial found no link to adverse clinical events.
How are fractures treated?
Depends. New stent, balloon angioplasty, CEA, bypass, anticoagulation, or just observation.
And finally, restenosis again, long-term.
Always a concern. Early trials with just angioplasty showed high rates, but CREST data with modern stents suggests much lower rates after TFCAS, similar to CEA at 2 years, around 6%. Long-term TFCA's risks still need more follow-up.
Risk factors for restenosis.
Diabetes, female sex, dyslipidemia, lesion length relative to vessel diameter seem to increase risk. Restenosis after TCR isn't well described yet, just not enough long-term data.
After the procedure is done, what's the typical post-operative surveillance?
Duplex ultrasound, usually around 3 to 6 weeks post-op. Need to establish a new baseline flow velocity because the stent changes hemodynamics.
And then?
Repeat surveillance at 6 months, then annually is common practice for all stented patients. Though, admittedly, there's no definitive RCT data proving the optimal schedule. It's mostly expert consensus to watch for restenosis.
Okay. Sounds like a field still very much in motion. Any key ongoing trials we should watch?
Definitely. Several big ones comparing TF-CAS-CAR versus CEA. ACST2 and CREST2 are looking at asymptomatic stenosis comparing intervention versus best medical therapy.
Interesting.
ECST2 is looking at intervention versus medical therapy in both symptomatic and asymptomatic moderate severe stenosis. And Roadster 2 is a post-approval study for TCR, looking at real-world efficacy. Preliminary 30-day results look very good.
So, lots more data coming. To wrap this all up then, what are the main takeaways from our deep dive today?
Well, I think while TFCS hit some bumps, with the stroke concerns and early trials compared to surgery, TCR has really injected new life into carotid stenting.
Right.
Both TFCS and TCRs can be safe and effective, but patient selection is absolutely key. Proper neuroprotection, optimal medical management, They're crucial.
And the data.
We still have limited large RCT data specifically for TCR compared to other methods, but the observational data we do have from Roadster and VQI is certainly encouraging, promising results.
But still questions remain.
For sure. Long-term results, especially stent patency, need more study for both techniques. And the role of any carotid stenting for asymptomatic stenosis is still a major area needing more investigation.
Okay. So a final thought for our listeners. Considering these rapid advances, especially in endovascular techniques and these ongoing trials, how different might the treatment landscape for carotid artery disease look in, say, the next decade? And what new questions might pop up as these technologies keep evolving?
It's a great question. It's such a dynamic field. I think we'll see continued refinement of techniques, better patient selection, maybe clearer guidelines incorporating TCR. But new technologies always bring new questions about durability, cost-effectiveness, and exactly which patient benefits most from which approach.
Definitely something to keep an eye on. It's clear this is a continuously developing area, and future research is going to be vital for figuring out the best approaches for different people. Thanks for joining us for this deep dive.